Oh, good afternoon, everyone. Thank you for
Hang on
joining.
a sec, Michael. Just wait for people to join us.
Okay. Oh, okay.
I'll do the opening too.
You want to you talk first?
Yeah, I'll talk first.
Okay.
Just wait for welcome everybody. Just wait for everybody to join us.
Okay. And if I want to stop the video, I do that. Okay.
Yep.
All right.
So looking like everyone's joined us. Okay, I think it's everybody now. Welcome to this webinar today on managing COVID-19 in the workplace. I'm Philip Aldridge from HASANS, Executive Director at HASANS. So I'm your host today and moderator. Got Dr. Michael Antoniadis talking, and just go over what from the occupational medicine perspective. So in terms of logistics, your attendees, you'll be muted and the video is off. And I encourage you to ask questions. At the bottom of your screen, there's a button called Q&A. So I encourage you throughout the session to put in those questions, and we'll endeavour to answer most of them throughout the next little bit. So Michael will talk for about 25 minutes, go over some slides, lots of information there, and the presentation will be available after the session. So yeah, I encourage you to ask the Q&A as you go along, and then there'll be plenty of time later on. There's already been quite a few questions come in previously. So Michael, over to you.
Thanks, Phil, and thank you, everyone. Thanks for joining us this afternoon. My name is Michael Antoniadis. I'm an occupational physician based in Wellington, and have a background in general practice, and then went into occupational medicine. I work primarily in the medical legal environment, but I have an interest in obviously the workplace and managing that safely and keeping a healthy workplace going. So I just thought, we had here Phil asking me to give this presentation. So I try to keep it as broad as possible and as general as possible, and I'll talk about that as we go through how some of the things are going to be generalizations, and it's difficult to be absolutely specific in this sort of with this moving target that we've got with COVID-19. Anyway, we'll get started. I'll just get rid of my video here. So this is what we're covering today. We'll just talk about the epidemiology briefly and the etiology about how this virus is spreading, the situation in New Zealand, a little bit about the symptoms, diagnosis, and the limited information we have on treatment, talk about risk factors, which I guess will interest most of you, and how to manage those risks in a risk matrix that's been sort of drafted. And we have lots of time for questions. I'll address the Health and Safety at Work Act, but I'm not a lawyer. So what we do know about COVID is it's a severe respiratory disorder when in some individuals, in most it's less than severe, but it is related to a large group of coronaviruses that affect both humans and animals, about 6 viral types in humans, including SARS and MERS, which are ones that have emerged in the last 20 years. It wasn't recognized until late December 2019 in China when there was an outbreak, and it was a range of 44 pneumonias that sort of developed and of unknown origin that led to them investigating that, identifying COVID-19. The source of the virus hasn't been proven, but the suspicion is that it's the ecological reservoir is in bats, and then through a intermediate host, possibly the pangolin, which people have seen pictures of, I'm sure. It was declared a public health emergency by the WHO in late January, and then a pandemic in March, on March 11, although a lot of countries had moved into pandemic mode before that. So a lot of this will be known to all of you, but we understand that it is transmitted through droplets, cough, sneeze, and even speech. Contaminated surfaces are also a source of infection, and these inanimate surfaces, they call them fomites, do harbour the virus, and they can maintain the virus from anywhere between a few hours and a few days. So the actual numbers, it's around 24 hours for cardboard and about 3 days for stainless steel and plastic. Close personal contact, again, rather than casual personal contact. So close is defined as less than 2 meters for more than 15 minutes, including being in a closed room. The infectivity, well, is a lot more infectious than influenza. And we think this is what the understanding is at the moment, that on average, a person who's infected will infect 2 or 3 others. Anything more than one, an RO more than one is worrisome, provides increasing risk of triggering a pandemic. Its greatest infectivity is at the time of first developing symptoms, and possibly before. I mentioned there the risk of asymptomatic spread is low, but has been described, and that's still being investigated and trying to be understood to give better information on that. In New Zealand, as of yesterday, these were the numbers: 1,401 confirmed and probable combined. 9 dead. There's 16 significant clusters. From that, the percentage of total cases is significant when you combine those clusters. And we've got a fatality rate of less than 0.5%. And WHO published their case fatality rate or mortality rate at approximately 6%, but that is changing. Yeah, difficult to interpret that, but we think it's we're going to fall into the region of possibly 2 to 3% worldwide. Community transmission in New Zealand is estimated at 2%. There is a number that is still being investigated that may change that percentage, but it seems to be very low at the moment, and hopefully stays low when we come down through the levels. And we're currently on level 4, looking to come down. So level 4 is quite restrictive, and I won't go through that. Down to level 3, some of the limitations are listed there. Few more businesses open, but lots significant restrictions still on hospitality and retail outlets, malls, etc. And mass gatherings are limited or largely cancelled. There are some detail around that. I think you'll find that on the government websites. Level 2, loosening again. I won't run through those, and we went through that level pretty quickly, and it will look different going down through the levels rather than coming up through them. And our understanding and tolerance of that will be tested. Symptoms: the majority will have a fever, the majority have a cough, and the vast majority will have those two, with other symptoms being common, but not as prevalent as fever and cough. And those are two that you can, quite useful for screening. Shortness of breath is very common, and this other symptom of anosmia or loss of smell, disturbance of smell and or taste, is quite common as well, but wouldn't be the only virus that causes that. sore throat, not so common. Loss of appetite, muscle aches and pains is, understandable and with viral illnesses, and not surprisingly is features with COVID also. Gastrointestinal symptoms, dizziness, headache are also common as you'd expect. Sneezing, runny nose, less common. There are this asymptomatic individual group, which they're still exploring, and it has been described, and there are some studies out of China and South Korea. The numbers are small in those papers, and so it's difficult to know how to interpret that. And the spread from asymptomatic individuals or pre-symptomatic individuals is low, but has been described. And as I said before, as soon as you become symptomatic, that's when you're most infectious, as opposed to SARS, when it was more through when you became quite unwell, but you were most infectious. There's 3 stages to this illness. We'll just touch on them briefly. There's the incubation period, and the average incubation period is between 5 and 6 days, but can be up to 24 days. And one study in a US journal suggested it could be as long as 24 days, which is a little bit more scary, but probably unusual. The 5 to 6 days appears to be the most widely quoted and experienced. And almost everyone develops symptoms within 11 and a half days of being infected. There is this symptomatic period, where most people will sit when they've got a range of symptoms, but they're not severe to the point of stage 3, where they've got an uptick of viral infection, and as a consequence, requiring hospitalisation, oxygen support, potentially through ventilation, artificial ventilation, and ICU care. But as I said at the bottom there, that most, more than 80%, are mild to moderate in severity, and won't require hospitalisation, as we see in New Zealand, as we've seen here, and that fit people can have severe disease, but they've got a better chance of surviving that. And I guess the best example might be present in hospital staff and medical staff, nursing staff that are caring for acutely unwell individuals. So I've only just put a couple of points in here about treatment and vaccination. It's all very much in the trial stage, largely hospital-based. I mean, there is anecdotal evidence, and it's all being explored. If people want more detail, they can request that. I've got something I think later on, not in the slide group, but I can pass that on if you'd like to know more. Vaccinations are being developed in many centres, and the hope is that there will be something to offer the world over the next 1 or more years. High risk. These are the group that we need to be careful of, and they do include individuals that are over 65. And this group of illnesses are being well outlined in the papers and through the official websites. Chronic obstructive pulmonary disease or CORD, respiratory disease of chronic nature, poorly controlled or severe asthma, uncontrolled cardiovascular diseases, including angina, hypertension, people that have had stroke and have vessel disease affecting their brain, poorly controlled diabetes. If people want more detail, I can provide that. Chronic renal and liver disease, including those who are receiving dialysis. Immunocompromised, that's still being teased out. And there's a wide range of individuals who may be immunocompromised, but not all will need to be isolated or kept away from the workplace or from the public. Morbid obesity, BMI more than 40. So that really reflects their risk of doing poorly on a ventilator, and also likely comorbidities that they may have, which may include diabetes or hypertension, for example. Smokers, and there was some thought that in China the increased number of males that experienced COVID-19 and suffered severe symptoms was because of this increased number of male smokers in China. But smoking does compromise your ability to manage respiratory illness as effectively. Recent surgery, and again, it's a bit of a broad term, but people need more detail, be on a case-by-case basis. Malignancy, especially those undertaking active treatment. History of travel, that might be to or from overseas or to or from an area where there have been an outbreak. That may be a situation we have to look out for in New Zealand in due course. Pregnancy, difficult one line, but could spend more time talking about that. But at the moment, we don't have evidence to support spread from the woman to the fetus, but that's still being explored.
Michael, Philip here.
Yes.
One question, just a very quick answer maybe, or very quick response. What about immunity? If you have it, are you immune?
Okay, yeah, we'll cover that later on. It's hard to be quick on this one. If we're looking at what other coronaviruses have done to us, and we have all experienced the coronavirus infection as adults, the chances are there will be a level of immunity. Whether that's long-lived is yet to be seen. It's more likely to be short-lived immunity. And the tests to check your immunity are still being developed. They're not specific or sensitive enough at the moment to be released, but that is being fast-tracked.
Might speed up a bit, Michael.
Yeah. So medium risk there, same sort of disorders, but less severe, and low risk are again mild asthma, for example, or well-controlled diabetes being the medium risk. The vulnerable bubble, these are individuals that you're living with in your bubble who you may have concerns about. And that needs to be teased out individually. And some of it may be best addressed by the Human Resource Department. Managing the risk here. It's a workplace hazard, an infectious disease that's well established, and the Health and Safety at Work Act does require an employer to take all practical steps to mitigate the risk and protect their workers from all workplace hazards, including infectious disease. So this is a risk table that Mark Floyd developed, occupational physician in Christchurch, that we had some input on, and it's a nice illustration. I mean, I think it is quite clear. It does leave some grey areas there in the mustard, which may encompass quite a lot of workers. We'll look at the work class for a start, and you've got probably an industry you're not going to see class 1 are basically directly interacting with COVID cases, and more likely to get in that class in 2, 3, and 4 for most industry. So there are those medium risk illnesses, well-controlled diabetes, for example, or hypertension. When you are coming, if you are potentially exposed to a COVID-19 patient where extra care needs to be taken and consideration needs to be given to, we can come back to that, but Just to move on, the hierarchy of controls. I won't spend any time on that. People understand that, I'm sure, in the group that's viewing here today. But basically, PPE sits right at the bottom. But I know there's a lot of interest in the PPE. But essentially, first principles, good personal hygiene, hand washing, soap or water at least 20 seconds, and hand drying is very important. Or you can use hand sanitizer, 60 to 70% alcohol is recommended. And every time you touch a potentially infected surface or item, you need to wash your hands. Good cough etiquette, cough into the elbow, tissues with safe disposal, and that comes into, you know, having maybe separate bags or bins where tissues are disposed of. Being aware of your own health and seeking medical attention early if you develop any symptoms, mild or any that raise any concern. Report that to your doctor or your employer. Getting immunised, having a facility to provide annual flu vaccinations is really important, because getting 2 viral infections would be catastrophic for many people. Administrative controls, I'll just quickly go through, open them up. Whoops. You're changing the way people work. So giving clear advice with regards to their entitlements for sick, paid, unpaid, parental leave, whatever it might be. Special leave may come into play here. Educating your workers on what the risk factors are, what the symptoms are, and so they know to stay away if they are unwell or becoming unwell. You may have to change the way you do your shifts to maybe reduce the number of staff on at any time, just to allow that physical distancing, minimising contact, particularly with people that you, customers or clients that aren't always in the workplace. Consider the risks around the staff room. Hot desking is best avoided, and supporting your workers to work from home. Appropriate fitting of PPE if indicated, with the appropriate training and obviously the care that goes with PPE, which we'll talk about. So the engineering controls, the 1 metre, 2 metre rules are difficult to be clear about. 2 metres if practical is best between workers, and using for physical barriers would be appropriate in some cases. We see that at supermarkets now. Cleaning and disinfecting frequently, again, using the, there are some, CDC do put some guidelines out about appropriate cleaning materials, including diluted bleaches. And obviously a little bit more if you are experiencing, if you have experienced a contaminated or infected worker. Good ventilation, maybe changing the way you, changing the speed of circulating air in the workplace, opening windows if you haven't got an air conditioning system. Just some other stuff about, you know, minimising the potential exposure between workers. Be kind. We're coming back to what we're being told. Look after your workers' mental health and well-being, and be acutely aware that they may be affected by this outside of what they're experiencing in the workplace. Offer flexible hours depending on the home situation, because they may have sick members in their bubble that they have to look after, and consider those who haven't got, they've got financial constraints, haven't got the capacity to get to doctors as readily as others. So Ministry of Health says some workers may require PPE, and they're not generally recommended. If you can, maintain the 2 metre separation from workers. And this is the recommendation on the WHO and even on the Ministry of Health website still talks about 1 metre, but I think 2 metres is safer if you can manage that. Consider glove use, and again, there's important things that you need to consider there with regards handling gloves that have been contaminated or between tasks, but maintaining basic principles, hand hygiene, physical distancing. Where you can't maintain physical separation, such as in prisons, healthcare workers, they do need the full gamut of PPE. That may include face shields as well as alternate clothes or covers, shoe covers, etc. This is occupational hygiene stuff. I won't spend too much time on this, but important that if you are having to use PPE, that you do maintain physical distancing. Coming back to a little bit of the new legislation, if an employer runs out of the essential PPE, they need to stop some activities until supplies become available. So there's a lot of talk, particularly out of the US, about cloth face coverings, and you've got to understand that they're not PPE. People are making them themselves. Scarves are particularly ineffective in protecting individuals, either who have got the illness and are trying to avoid spreading it, or vice versa. But there is some recommendation from the CDC, possibly because of the volume of disease they have there. So some things to look forward to: be responsive as things change, as we go through the levels, as we understand more about the disease. What we talked about today may not apply tomorrow. The issues around antibodies, the issues around immunity, the issues around treatment options will undoubtedly become clearer as time goes through. But going back to those websites, official websites, WHO, Ministry of Health, and they keep very up-to-date information. Oh yeah, that's just a disclaimer. Plan ahead and anticipate disruption for a long time going forward. It's a marathon, not a sprint. So if you do have to put up perspex shields or make adjustments to shifts, that is something that is likely to be a long-term requirement, particularly for the foreseeable future. We don't know the end, when the end is here. So here we go.
Thanks, Mike. Michael, that's great. Perhaps if you want to share your screen and put your video back on. So thanks for that. I know people have lots of questions coming through. So if you've got more questions, fire them up via the Q&A at the bottom of your screen there. Thanks, Michael. And we'll start going through a few of them. Just one thing for everybody. Some people want to see those slides again, so they'll be available on the HESNES site, and we'll also send it out after the a PDF version after this to participants. So, question about taking temperatures from Sarah. Thanks, Sarah. Some say it's not reliable. So what's your thoughts on people taking temperatures to see if they are symptomatic?
Sure. There's probably, well, there are 4 ways you can take a temperature. So you've got it through tympanic membrane, which is the most reliable. The other ways are classic in the mouth, and axilla, which is in the armpit. That probably sits as 2 and 3, and then the least reliable is the forehead temperature. So if you're gonna do it and do it properly, you purchase a tympanic. You purchase a thermometer that allows you to measure it through the tympanic membrane. That gives you a core temperature, which is accurate.
Thanks. This might be a bit of a hard one, but sort of use of mess and spray bottles to clean down vehicle cabs, or diluted Dettol would be best. Do you have any thoughts on that? What sort of cleaning methods are appropriate?
I'm not sure about myths. I found the CDC website has a very good section on cleaning equipment, including using diluted bleach, which is, to me, sounds most cost effective. But I would direct you either to the Ministry of Health or at cdc.com, which is the US website, for appropriate disinfectant use, because you also want to protect the surface that you're cleaning. And that, that may vary depending on on those individual surfaces. I'm not sure if I'd want to put bleach on my laptop.
No, it wouldn't be too good for it. With regards to asymptomatic contact or contact spreading, would using a mask, even homemade, be useful? I think you might have answered it already.
So they're asking if you. So I'm not quite sure what that means. Are they asking if people have been in contact and they think they've contracted it? They're asymptomatic, would a mask save them from spreading it to other people?
Yep, I think that's what they mean. Yes.
Look, if you have close contact with a known COVID patient and you want to be ultra cautious, we know what the incubation period is, and that most people become symptomatic within that period of time. Up to 14 days and maybe longer, but 14 days, there may be a place, if you're ultra cautious, to be wearing some form of mask. But I think that the jury's still out really about asymptomatic spread. The risk would be low because the viral load is likely to be lower than it would be if you are at the big early stages of being symptomatic, which is the most infectious period.
Great. Just in terms of resources, Tony's written Safe Work Australia has got some great material. Thanks, Tony. Do you, Michael, have any thoughts on where the best places to go to for resources?
Well, I've actually got the references I used, I've got listed in the bottom of my presentation. Basically, the Ministry of Health, WHO, and CDC, and the equivalent in the UK give sound, up to the minute, accurate as you can be, and you have to keep checking back there for some of the information because it changes. Advice. That's where I would go, and I've recommended that to everybody that I've talked to about this, friends, family, and clients.
Right. There's a question from Peter. Thanks, Peter. There's concern that this has been addressed as a respiratory issue, while some doctors in New York City suggest it might be more like an altitude sickness. What are your thoughts that it's more like an altitude sickness?
Oh.
What are your thoughts around that?
What sort of sickness, sorry?
Altitude.
Attitude? Oh.
Altitude.
Oh, altitude. Oh, sorry, altitude. Sorry. I don't have a. I can't really make a comment on that.
Okay.
I mean, it's a respiratory illness, but it is found in other parts of the body. It is identified in the gastrointestinal tract, in the gut. It is identified in fluid that surrounds the brain. It has been sampled from other areas, not just the lungs. So it is a sickness that can give you diarrhea, for example.
Okay.
Sorry, I can't answer that question.
That's right. Question from Linda. When do you think we can recommence lung function testing, blood or breath alcohol testing, or in fact any health monitoring in the workplace? Do you think this is a long way off?
Yeah. I mean, I think, again, it's about risk management and about, do we really need to do these tests on these individuals, and can we spread the timeline out? So I think there may be situations where people have to have formal lung function tests because of particular more severe respiratory condition that's deteriorating, but that would be best done in hospitals at this stage. I would say, at least while we're in this with these restrictions in place. And I think, you know, yeah, coming back to the asymptomatics, if we're doing it on asymptomatics, we're asking for a bit of trouble there potentially. Yeah.
Yep. There's been reactivation of COVID-19 infection in South Korea. Is there any extra considerations that should be given to staff members returning to work post-19 infection? Do you have any insights into sort of reinfection or re-establishment?
Yeah. So reactivation, there's been a study out of China with a small group that I may have mentioned, and 9% came back reactivated. The numbers are too small really to make sense of that, and similarly out of South Korea, I think more work has to be done on the reactivation theory. There's been no proven reactivation in New Zealand, as far as I'm aware. When it comes to returning to work from a proven COVID-infected patient, the current attitude is that you need to be at least 7 days after the onset of illness. You need to be at least 72 hours without symptoms, including fever, and without symptoms and without the use of anti-fever lowering medication. And then you're okay to go back to work. In some places, so there is a testing component to it, where some people request someone to have a negative COVID test. In fact, initially it was 2 COVID tests some days apart, but most people have settled on the non-testing way of clearing people coming back to work. Of course, that may be different for healthcare workers, where I think in the DHBs they'll be asking people to be tested and be negative before they come back to work. But I think in industry, I think that managing without a test is fine.
Just in terms of that fitness for work question, which you started to allude to, question from Tina, have you got any thoughts on guidelines for the fitness for work criteria, particularly when they were asymptomatic? She suggests that you could ask questions around travel, contact, symptoms. Are there anything else you could be asking or requesting?
Sorry, just say that again.
So basically, what I can understand from the question, she's wondering about guidelines around fitness for work, particularly where people are asymptomatic. She can ask questions around travel, whether they've travelled previously, contact with people that have been affected.
Sure.
Do they have symptoms?
Sure.
Are there anything else that they could be asking or should be asking?
Well, I think it's important, obviously, to know if they do have a questionnaire, that they list the high risk and probably medium risk disorders, and have those available to those people coming into the workplace to make sure they're not coming in with any high risk diseases. Yeah. Yep.
There's a question here, it might be a slightly weird one. Someone asked about foot lesions. Asked, how valid is a symptom around foot lesions in COVID-19?
I have no idea. I've not heard of foot lesions associated with COVID-19 in mild to moderate cases. Like I said, it's a multi-system disorder, and when symptoms are severe, you have major organ failure, which may include disorders of the skin. I don't know. Okay.
There's a couple of questions around cleaning processes. So a lot of people have been out of work for 4 weeks. They bring cleaners back into the workplace, so introducing unknown people. Therefore, does that increase the risk of contamination?
Oh, so the cleaners are coming in at night to clean the office?
Yeah.
Right. I mean, I think it would be on the with the cleaners there. You know, I think from the point of view of what you're presenting the cleaners, that you have areas where cups or tissues are disposed of in separate bags, and then you've got your the cleaners coming in with their undoubtedly they'll have some gear depending on what they're cleaning. They may well have masks, they may well have gloves, and they'll have a process. I would like to think that on both the you know, the cleaners company side and also on your office side, there'll be there'll be mitigating ways to mitigate all that risk. I think that's
yep. Question around PPE and masks again. No doubt we've got lots of questions about masks. So if we are to take all practical steps, why wouldn't we use masks and disposable overalls? And this person seems to think in countries like Germany, China, Korea, they're doing it anyway. So why don't we follow examples from overseas?
Well, I think
on the spot of it.
Question to answer. There is a supply issue. I'm sure, you know, if everyone everywhere starts using gloves, overalls, visors, masks, goggles, gloves, there will become a supply issue. And I don't think it's good practice because it actually gives people a false sense of security. I think we have to go back to first principles. I don't want to repeat myself, but we go back to first principles and you go through the hierarchy of controls. If people are uncomfortable with that, then individually they need to have that discussed with them and try to reassure them if it's appropriate. If not, they, you know, if they're not comfortable with it, they need to be able to express the reasons why they're not comfortable with the process that an individual company's taking.
Yep. Okay, question here around contact tracing. So this person has produced a form for, I presume, the employees to use for contact tracing. Each person retained their own form to ask for it by Ministry of Health. Employers would only check the form to ensure they've been filled in to avoid privacy breaches. So basically they're asking their staff to have contact tracing or have track what they're doing. Any comment on that?
Yeah, look, I think I think getting into level 3 and having more people in the workplace, I think it is important. And so, but it is obviously handy that you know your co-workers, you know who they are, and you may, in most industries, have limited contact with customers, clients, as you would do in hospitality, as you would do in retail. So having a list of your contacts is really important. So the contact tracing is made a lot easier. So I think it's totally feasible in the factory industry setting, less feasible in the retail hospitality industry which remain closed. So I think it's a good idea. Obviously the the Privacy Act will deem how information is stored.
Okay. Sort of one we've already partly answered, but it's around the usual annual health monitoring done by occupational health nurses. Should that be put on hold until we return to a level 1?
I think not essential physical examination of individuals is inappropriate at this stage, unless people are unwell, where they need medical attention face to face. And I think that definitely in level 3, telehealth type consultations will be encouraged for primary care providers. And I'm not sure what happens in level 2. Like I said, going into level 2, we had face to face, but that was only for a brief time. So yes, I think it is, unless it's essential, it's probably best avoided.
A couple of questions around schools and teaching and children. Looks like they can, under level 3, have some sort of children come back to school, sorry. There's a lot of concern from teachers around return to classroom settings with children who may or may not be following instructions well. Also, the ability to sanitize as much as they want to, reading your keyboards and whatever else. So really the question is, what are the risks around kids going back to school?
The risk for the teachers?
The risk for the teachers, risk for the kids, I suppose. Yeah.
Yeah. Look, the risk, I mean, I think you have to, again, go back to those first principles. If they have any symptoms, they stay away. So again, they may be, there may be some sort of questions asked of the children before school starts to make sure that anyone who is unwell or has developing symptoms is kept away, and obviously that needs to be made clear to the parents in some formal way, newsletter, or I don't know, email, however they normally would correspond with parents. I know that it's difficult because parents have their own pressures of going back to work as well. I'm not sure there's any easy answer there. It would take a bit of thought, I think, to tease out.
Yep. Here's a tricky one around PPE again. I've heard of a rest home facility where face masks are being autoclaved and reused. Staff were told this was advised by the DHB. Can you confirm if this is correct? You don't have to answer this question if you don't want to.
No, yeah, I would refer you back to the ministry with regard to that. I don't know the answer to that.
I think we covered off most of the questions. Try and check. There might be some in the chat. Let's double check. So if you've got any questions, fire them in by the Q&A rather than the chat. Got a few more minutes left if you've got some more questions. Just looking through the list. Some people put some information on chat, so have a look at that. There's some stuff there about close contact and things like that, so that's good. Just a question around temperature taking again. If air temperature, the physical air is used in the workplace, should they be cleaned after each time? If you do an air test, hearing air temperature test.
If someone is that to do with temperature?
Yeah, temperature, yeah. Testing it rather than throat using the air test.
Oh, sure. I think you have to look at the device, the instructions on the device. I'm not sure if some of them do have disposable probes, and others will have ones that you may have to clean. But I think obviously it makes sense to have a disposable probe.
Yep. Question here. Would Ministry of Health be the right reference return to work? Not quite sure what they're looking for. They're probably looking for information or resources, I expect.
Well, yes, I'm not sure. I mean, there is, like I said, for healthcare workers returning to frontline medical and health care, they may require a negative test. But in industry, it's in most cases, if you're asymptomatic for a period with that with those other factors, including being 10 days from the onset of your illness, having no symptoms for 48 hours, then it's appropriate that you can look at returning to work.
I do know that just for the people on the call's information, that the Forestry Industry Safety Council, which is under Trade and Unsafe Tree, and Chazan the Construction Health and Safety have got material in the process of coming out for their sectors, because it look like the forestry and construction sectors will be up and running shortly. So they'll be giving advice to their businesses. And the Business Leaders Health and Safety Forum is also pulling together stuff for CEOs. So there is stuff about to come out or will shortly come out. And I think the MB, Ministry of Medicine and Innovation, is producing some stuff as well. So hopefully in the next few days, before we get into, if we do go down to level 3, there'll be more material around.
Yes. Yeah, I think some of these things may change over time. Well, I'm sure that
I
will.
agree.
Yeah.
I agree. There's a straight question around cleaning. Do we need to clean our workplaces before staff come back to work?
They've been unoccupied.
I presume so. Yeah, I presume I'm occupied for 4 weeks.
Yeah. Well, we understand what. I mean, other than clearing the dust off. I mean, the virus survives on a surface, on a hard surface for up to 72 hours. So
It'll be okay.
I don't know that you're going to find COVID if you start swabbing surfaces that have been unoccupied for 2 weeks.
Okay.
Longer. Yeah.
Okay. Just to follow up on that previous question, is on the chat. Nikki says Chazan's just put some information out today. Very good. So that probably, or certainly applies to construction. But I think
Sure.
that probably has some relevance across all sectors. So just a question from Margie about working in a manufacturing environment where distance will need to be maintained. Should those workers with chronic disease or immunosuppressed be allowed to work at level 3 or advised not to? So people that are high risk, should they be allowed back to work at level 3, particularly when they're sort of in close contact?
Okay, so high risk illnesses are the ones that I listed. Immunocompromised needs to be teased out. So I put it in the high risk section, but they're not all high risk. So it may be that needs to be individualized. And again, just going back to that risk matrix and trying to apply it to those workers and their if it's a manufacturing role and they can keep their distance, they can maintain good personal hygiene, and they are yeah. I think you just need. Sorry, I think it's just hard to generalize, but I think you've just got to go back to those first principles and look at that matrix. And there may be individual people that have to have a consultation with a medical professional, to a doctor, occupational physician, GP, if they're happy to do that, to decide, looking at what the companies put in place to protect their workers, what their individual health situation is, and then working out that risk from there.
Okay.
So it's hard to be precise.
But certainly if people are high risk, you'll be putting processes around it or do some active management.
Yeah, I think the management should be put in place for everybody, and then you see how that works for a high risk individual.
Yeah. But I think the other point to make, I think you'll probably agree with, is that people have to take personal responsibility as well.
Yeah, my understanding also is that the DHBs, there's not a huge number of confirmed high risk individuals, even in that setting, where clearly those individuals that are coming in close contact with COVID patients are being found. So hopefully the numbers aren't big in the industry.
Okay. Just seeing if there's any more final questions. Got a couple of minutes. Just one question here from Clayton. Probably the final question before we wrap up. Actually, someone says Hort NZ has got good information on their website, so that's great. Hort NZ, Horticulture New Zealand. So a question, again, when the government talks about elimination, are they referring to the virus? I presume that's a yes.
Yes. That's the goal of level 4. We haven't managed to achieve that, but we've managed to dampen the fire enough to go down to level 3 and test the water there, really.
Okay. I think that's about it. We're about running out of time anyway. So thank you, Michael, for your time, and thank you for panelists coming on. Hope you got something out of that. So we'll send out the presentation to you after this in the next couple of days, early next week, once we get back to work. And Michael, thank you for your time. I hope you stay safe, and everyone else stay safe. So thank you for your time today, Michael.
Thanks.
Thank you out there.
Thank you.
Take care. Good night.
Bye.